Good evening. I always forget to use the disclaimer that I am not a professional. Okay, I'm not a professional, but I do often try to find confirmation of the things that I say. Give me just a moment. And so today, I bring to you some confirmation. Now, I want to apologize in advance. I am suffering from a I'm suffering from some hives. I fucking middle of the day broke out. I just took some allergy medicine, and hopefully that'll clear up. But you might hear some scratching. Again, not a doctor, not a medical professional. I've just done a lot of research, and so I want to start this conversation off today with saying I do discourage against using medication, but there is a time and a place for medication. Okay? One, if you're on medication, don't just stop taking medication. Wean yourself. You don't want to go down that rabbit hole. It's not funny. It's not funny. You will end up dead. Okay? Two, if you are experiencing like severe discomfort as a result of whatever illness you are experiencing, mental illness, I would definitely talk to your doctor about medication, because sometimes your levels get too low where you can't necessarily build it back up without. And you might want to do a small regimen. I would say at least a month. Because it's like this. They tell you when you take medication, some medications you need to take for at least 2 weeks. Some medications you need to take for at least a month. Okay? But once you get to that point, immediately start weaning again. So if it's 2 weeks, at 3 weeks, tell them to take you back down in dosage until you're off of it again. Got it? Make sense? Okay. Why am I saying this? Because I've done it. Because I did it. I'm speaking from experience. All right. So, the first thing that we're going to get confirmation for today is my video in regards to medication. That video was called Coping Skills. And the second was, I said what the F I said. All right. So, as soon as I find it, because for some reason I lost it. I should have been ready for this. And somehow I'm not. Did I accidentally close? I must have closed it. Oh, Jesus. I'm so sorry, guys. I really be trying to be ready. I don't mean to be having y'all sitting here. But I'm not going to start over, because that was like literally the perfect... Damn it. That was literally the most perfect intro. There it is. Okay. This article is published by Mad in America, Science, Psychiatry, and Social Justice. madinamerica.com. All right. And the person writing today is Peter Simons. And Peter Simons' credentials he is an academic researcher in psychology and a science writer. He tries to provide the layperson with a view into the sometimes inscrutable world of psychiatric research. All right. So, he is going to be quoting psychiatrist Nasir Gaimi. And according to this psychiatrist, Nasir Gaimi, Most psychiatric drugs are only effective at treating symptoms in the short term, like taking aspirin for pain, and don't improve the long-term course of an illness or prevent hospitalization or mortality. So let's think about it in this sense. You get migraines. You get migraines all the time. And you take an aspirin, you take a Tylenol, take an ibuprofen, whatever you choose, right? And you do that for like years. And come to find out, this whole time, you actually had brain cancer. The Tylenol simply helps the symptom. It didn't solve the brain cancer, right? Okay, so this is how he is comparing psychiatric drugs. Okay, let's move on. Most psychiatric drugs have not been proven in properly designed randomized trials to improve the course of any illness they are purported to treat. Specifically, they have not been shown to prevent hospitalization or extend life as many clinicians believe. And this is what Gayemi says. He is a renowned psychiatrist based at Tufts University and Harvard Medical School. In addition to his medical degree, he is also has a graduate degree in philosophy and public health. He specializes in depression and bipolar disorder research and has authored textbooks in various aspects of the field. His notable textbooks include A Clinician's Guide to Statistics and Epidemiology in Mental Health, a textbook on clinical psychopharmacology, and Mood Disorders, a practical guide. Okay? In his new article in Acta Scandinavica Psychiatrica, Gayemi writes that disease-modifying treatments as found in the rest of medicine are concerned with improving the course of illness and preventing death, but psychiatry's drugs are ineffective for this purpose or even harmful. His examples are psychiatry's two mainstays of treatment, antidepressants and antipsychotics. For instance, he notes that antidepressant treatments increase suicide attempts, at least in some populations, and doesn't decrease them in any. It is well known that standard antidepressants do not reduce overall suicide rates in so-called major depressive disorder, and in fact increase suicidal ideation and attempts in younger adults and children based on randomized data, he writes. And I find it really funny that he says so-called. So-called means like you don't really believe in it. He's a psychiatrist. Why he call major depressive disorder so-called? And I will also add, from experience, and not necessarily experience, watching someone else's experience. See, me, myself, I could never get prescribed any really hard-hitting medications in regards to anxiety. But I had a friend who took benzos and they prescribed it for a long time, and she ended up experiencing very adverse reactions that affected her brain in such a way. And I think he actually speaks on a similar effect. So let's see what else he has to say here. Okay. Likewise, he notes that antipsychotics don't improve the course of illness and instead have neurotoxic effects that reduce brain volume. In most studies of antipsychotics, the course of illness remains chronic and deteriorating. It is not reversed with long-term antipsychotic treatment. Pathophysiologically, antipsychotics, both older and newer, have a neurotoxic effect and reduction of brain volume with long-term treatment. And that's exactly what she experienced with benzos. She ended up getting holes in her brain. Okay, so Gayemi writes that the main difference between psychiatry and the rest of medicine is that psychiatry's drugs are symptomatic, treating only the symptoms in the short term, while the rest of medicine involves disease-modifying drugs which improve the course of illness and reduce outcomes like hospitalization and death. Most psychiatric medications are purely symptomatic with no known or proven effect of the underlying disease. They are like 50 variations of aspirin used for fever or headache rather than drugs that treat the causes of fever or headache. Gamey writes, and that goes back to my analogy. Okay, you could take an aspirin for a headache, but you actually might need chemotherapy to get rid of a brain tumor. Okay, so for comparison, he notes that research in psychiatry focuses on symptom reduction. In contrast, in other fields of medicine, symptom reduction is not the concern. Instead, hospitalization and death are more important. He compares drug development and heart disease with psychiatry. For new drugs and cardiovascular disease, researchers do not bother to measure chest pain or dyspnea. They simply measure time or myocardial infarction or mortality. In psychiatry, we measure symptoms of depression and anxiety and psychosis as primary outcomes. Studies usually do not even measure time to hospitalization, and mortality is not even on the radar. He also adds that some drugs for heart disease, such as antihypertensives, don't improve any symptoms in the short term, but they do successfully improve the overall course of the disease, helping people to live longer and suffer fewer heart attacks. This, he writes, is because these drugs act on the actual biological pathways that cause the disease, but psychiatry's drugs don't do that. Why do you think that is? After everything that I've shown you, why do you think that is? Because the cause is actually external. The cause is external, and the rewiring of the brain is because of the experiences and not necessarily genetic in a sense of they were born this way. You understand? So you have a heart defect, you have issues with your heart in regards to your internal. So like your heart is clogged because you ate a whole bunch of burgers, right? There's the easy fix for that. The same can be said of mental health disorders, but they don't view the brain like they do other parts of the body. Anyway, biologically, antipsychotics are mainly dopamine blockers, and standard antidepressants are mainly monoamine agonists, or serotonin. After their introduction in the 1960s, corresponding theories arose regarding the dopamine hypothesis of schizophrenia and the monoamine hypothesis for depression. Half a century of research has disproven this hypothesis. Dopamine overactivity and monoamine depletion are not parts of the pathogenesis of schizophrenia and depression, respectively. He adds, hence, from a biological perspective, antipsychotics and antidepressants are not disease-modifying drugs. This would be acceptable if they had a clinical effect, even if the biological pathways was unknown. If the drug successfully saved lives or prevented worsening illness, they would be successful. But he writes, a consensus of schizophrenia experts has reviewed the current literature and concluded that antipsychotics do not worsen the course of schizophrenia, but they were not able to show that these agents improve the course either. In fact, so basically what he's saying is it doesn't make it better, it doesn't make it worse, but it does damage the brain. Like they won't have any greater symptoms or anything, but there will be damage to the actual physical body itself. Okay, and for antidepressants, the FDA meta-analysis found no benefit with antidepressants versus placebo after 6 months of treatment. Gamey goes on to take issue with the poor validity of psychiatric diagnosis, mainly as they are defined in the Diagnostic and Statistic Manual of Mental Disorders, now in its 5th edition. The process of defining the DSM-5 definitions has been influenced heavily by non-scientific factors. and has not proven successful in biological and pharmacological research, he writes. However, the APA is fully committed to the DSM-5 ideology and unwilling to allow more scientific approaches to diagnosis, including covert emotional incest, provided by psychiatrist Kenneth Adams. The fuck is Kevin? Anyway. The National Institute of Mental Health has acknowledged this problem and no longer uses DSM criteria for biological research. And he did say that there's one exception, and that is lithium. Only lithium has been proven to prevent completed suicide in randomized clinical trials in psychiatry. It is the only drug in psychiatry which is proven to be disease modifying. However, this is the end of the article, and it doesn't exactly say why that is. And I would like to know more information about that. But I think lithium isn't necessarily a chemical. I mean it is, but it's like a natural one. Like I think you can find it in nature. Can you? Let me verify that. Can you find lithium in nature? The metal is not found in nature, but it's nearly in all igneous rocks and in the waters of many mineral springs. So it is a natural mineral, right? That they modify in order to make it the medication that we know. It's literally volcanic rock. You have to be in my head to know why I'm laughing about that. But anyway, so that is the first confirmation. That confirmation is for coping skills. Okay. Medication is not to, it does not cure anything. And so when you have these people that have been on medication for years and they haven't seen any improvement and they have to continue to up their dose and stuff like that, that's why, because it's literally not for long term. So that's it for this video.